All right. Good morning, afternoon, evening, everyone. Welcome to the International Ophthalmic Floater Society webinar series 2022, where today we're going to talk about floaters and beyond, and really the applications of YAG laser technology for the treatment and identification of floaters. And I have a fantastic moderator with me, Nathan Chaudhary from up in Canada. What's up, Nathan?
Hey, everybody.
What's up? And I know we have great topics today. We're going to talk a lot about floater, of course, the quality of life. I think that's something that I know we've all talked about, how we've been, I think, appreciating more now than ever before the impact floaters have on quality of life. And we're going to have Ahmed Al-Masri from Egypt talking to us about floaters and quality of life. And then we'll talk about how to diagnose the floaters. Andy Dimitriou from Poland, a good friend of mine out there, who's done floater treatments now for many years. And then I'll talk a little more about the principles of YAG technology and the procedure itself, some videos. And at the end, Nathan's gonna talk about some real life case presentations. And of course, we'll have discussions in between all those presentations. So with that said, I want to get started so we stay on time. I'm going to stop sharing my screen. I'll have Ahmed share his screen. We'll talk a little bit more about the quality of life and floater treatments. So thank you all so much for coming and appreciate the opportunity to help educate.
Thank you, Paul. I'm going to share my screen. To start playing my video.
Our experience in the vitreous floaters, how to treat them, how to use the YAG laser vitreolysis, and how to deal with them, even with the pars plana vitrectomy, and the whole problem of the vitreous floaters. I'm professor of ophthalmology. I'm Ahmed Al-Masri, professor of ophthalmology, former head of the ophthalmology department, Alexandria University, Egypt, and I don't have any financial interest of the materials in this presentation. And I would like to thank Dr. Shaima El-Basyouni with me in the preparation of this presentation. So to start with, to ask ourselves, is vitreous opacities a common problem, or it's not a common problem? Actually, it is really a common problem. This is a photograph that I took for one of my patients with the ordinary 78 non-contact volc on the slit lamp to show how big is the floater, how the floater is bothering this patient as it moves in front of his visual axis, and causes a lot of disturbance for him during driving, during seeing any distant object with the clear vision behind. So these are collagen fibers in the vitreous, which may form bundles which can pass across the visual axis as floaters. Over the age of 45, the hyaloid may separate from the retina and float across the visual pathway. So it's called as a vitreous membrane. So one of the key points for the treatment of these vitreous floaters is to have a total posterior vitreous detachment. This is rule number one. So why we should treat, or why these floaters to be treated? First, definitely, it's a common problem. And this common problem results in patients who are suffering during their work, driving, and reading, and watching the TV and using their computers, and it affects their quality of life. And this is our main issue in this presentation, to assess the quality of life with the vitreous floaters. And again, it's an easy way to be treated for these floaters with the different techniques of whether YAG laser vitreolysis or pars plana vitrectomy. The symptoms of these vitreous floaters, just to be clarified for the audience, that these floating cells, if they are float in the anterior vitreous, they could be ignored. But if they are in the mid or the posterior vitreous, they are definitely visually significant. It affects the vision of these patients, as you see, as if you are wearing glasses which are not clean, or these black spots in front of you, and all the image is really not a good thing. Okay, so let's see what are the types of these floaters. We have two types. From our point of view, whether treatable floaters with the YAG laser vitreolysis or non-treatable floaters with the YAG laser vitreolysis, and they have other ways of treatment. So let's see what are the types of non-treatable floaters. These floaters are due to vitreous shrinkage, or due to vitreous degeneration, or even due to vitreous hemorrhage. Those due to vitreous shrinkage that looks like very small worms that are moving in the vitreous, that are very difficult to be treated with YAG laser vitreolysis, as you cannot focus on these small cells, and actually even if they bother the patient, you cannot make the patient satisfied with this small floaters. Or if there is shrinkage in the vitreous, also it is very difficult to be treated with the usual laser treatment. Or due to vitreous degeneration like the synchisis scintillant. So this vitreous degeneration to be treated with laser vitreolysis, and these patients, if they are annoyed, the only way of treatment for them is the pars plana vitrectomy. Again, vitreous hemorrhage with all its causes, whether from the diabetic retinopathy or from vein occlusion with a branch or central vein occlusion, or from retinal breaks. The vitreous hemorrhage is not treated with YAG laser vitreolysis, and there are other ways of treatment like to wait until it subsides and absorbs by itself, or to do vitrectomy for cases of advanced vitreous diabetic retinopathy with the proliferative vitreoretinopathy. And so these are the non-lasered floaters, but the lasered floaters, or the floaters that could be treated with YAG laser vitreolysis, are those floaters pulled off the internal limiting membrane by posterior vitreous detachment. And again, I'm stressing, for any patient who needs to do laser vitreolysis, you should have total posterior vitreous detachment. So the timing of doing the floaters is not immediately once the PVD occurs. We wait not less than few months till the till we are sure 100% that the patient has total posterior vitreous detachment and not partial vitreous detachment, and to be sure again that the patients are annoyed from these floaters and they are not adapted to it. Here we can do the YAG laser vitreolysis safely in order not to pull on the retina or to induce any retinal breaks. So this is more in young myopes. Start with in selection of patients, as we are going to describe. Select the high myope patients, young age or old, the older are better, the pseudophakics, and the small size floater. And the size and the side also will be discussed. So this young myopes with this vitreous floater could be treated, but of course the percentage of success differs from one patient to another, and all of the time be toward the pessimistic side, having less percentage of success than the expected one. Again, cobwebs also could be treated with the vitreolysis, but they need a lot of sessions more than the expected, as you know. And as will be discussed, we may do from 3 to 5 sessions for floaters to vanish, and each session up to 500 shots. So we never ever give the patient fixed number of shots or sessions, as it depends on their satisfaction. Lastly, if you have an operculum or retinal break, of course, after treating the retinal break with the argon laser photocoagulation, you can treat the operculum with the YAG laser vitreolysis if it moves in front of the patient's field. But honestly, this is a rarity to be treated. These are the types of the treatable vitreous floaters. Okay, patient selection. Again, this point will be discussed, but I'm just describing this point in my presentation to differentiate between the symptoms that the floaters with discrete dark masses, these are the treatable one with the YAG laser vitreolysis, or the vitreous phase haze, these are untreatable vitreous floater with the YAG laser vitreolysis, and they need other ways of treatment like the pars plana vitrectomy. And the symptom severity depends on the size of the vitreous floater, whether it's an anterior or posterior location, as had been described before, whether it is central or peripheral, and the personality of the patient. It's very important to stress on the type of personality of the patients. The demanding and the patients are usually, you have to give them lower percentage of success than expected. Okay, patient counseling, again, depending on their expectations. You have to draw the vitreous floater to know what you are treating. And what we are treating is what the patients complain from, but not we are treating something that the patient is not complaining of it. So the percentage of improvement and preparation of the patient, and also, of course, the quality of life of this patient. So the doctor's-patient relationship, when we rule out pathology, we tell the patient they don't have any problem or any disease on your vitreous or retina. Actually, this is good for most of the patients, but it is this advice is apparently frustrating and unfulfilling experience for patients with vitreous floaters from their point of view. They are feeling something, they are seeing something, and the doctor ignores this thing, and this frustrates these patients. So the subjective experience of sudden floaters is very common after the total posterior vitreous detachment or partial vitreous detachment. And while many patients complain that this is bothersome them, but ophthalmologists tend to pay little heed to these symptoms other than to rule out anomalous posterior vitreous detachment manifesting as either peripheral or posterior retinal pathology or retinal breaks. Unfortunately, once the absence of disease has been assured, the typical eye care professional ceases to be concerned about the issue of floaters. The quality of life is utility values allow an objective quantification of the functional quality of life associated with the specific disease state. So when we say that the utility value or the quality of life is 1, implies a perfect health state, while death has a utility value of 0. The vitreous floaters' utility values are equal to the age-related macular degeneration and lower than diabetic retinopathy and glaucoma. So comparing to local diseases, the quality of life is affected as the AMD and glaucoma and diabetic retinopathy. And for the systemic disease, the floaters have lower utility values than mild angina and mild stroke. So floaters have a significant negative impact on the quality of life as compared to ocular as well as systemic diseases. There was no difference between the acute floaters that occur after less than 1 month or chronic floaters, which is more than 1 year for the patients. In both situations, the complaints are the same, and the patients are affected and annoyed from these floaters. The retinal magnification of the image associated with myopia can make floaters seem to be more pronounced. That's why the high myopes are more pronouncing their symptoms than the ordinary population due to the retinal magnification of the image. And there was a study found that these patients were willing to take an 11% risk of death and 7% risk of blindness to get rid of the symptoms which are related to the floaters. And this study, the authors state that the patients with floaters are willing to trade off TTO is a big number of 1.1 years out of every 10 years of their remaining lives to get rid of their symptoms of floaters. So can you imagine that one of my patients told me that he may commit suicide from his vitreous floaters? Another patient who was a pharmacist, he couldn't drive whether at night or in the morning due to the floaters. And after I did him YAG laser vitreolysis, he can drive safely at night and at the morning, at the daytime or the nighttime safely. And he was very appreciating the technique and asking why not all the ophthalmologists have an idea or with the YAG laser vitreolysis to get rid of these floaters, which definitely annoys the patient more than the doctors. In conclusion, symptomatic degenerative vitreous floaters have a negative impact on health-related quality of life. Younger symptomatic patients are more likely to take a risk of blindness to get rid of the floaters than older patients. Take-home message: persistent visual floaters can substantially diminish the patient's perception of their life and can be measured by the trade-off utility values with high reliability and constructability. At the end, I can say we are on the right track to treat these floaters by any means, whether the YAG laser vitreolysis or even the pars-plana vitrectomy that will be described in the next presentations with my eminent colleagues in the next few hours. Thank you so much.
All right, thank you. That was wonderful. We're going to have a discussion in a second here. You brought some really good points, but before we go into discussion, we have some polling questions that we're going to ask you guys all in the audience to answer, because it kind of gives us an understanding of kind of where everyone's at in terms of floater treatments and in terms of what you're doing currently in your practice. So here's the first question we have in our screen here, and please feel free to answer. Just click whatever question or whatever answer you have here. So the first one is, how do you evaluate vitreous opacities? There's multiple choice here, so you can actually go ahead and just click the different ways in which you currently evaluate floaters. We'll give you just a few minutes here, a few seconds to answer that, maybe more than one. I'm gonna also ask the panelists after this to answer their question. Probably after Andy's talk, we'll answer this question more and see what everyone else on the panel does. All right, so mostly clinical exam, some OCT, fundus, SLO imaging, and others. We'll actually talk about that. Thank you for those answers. I appreciate that. And we're going to go through some of those answers as we have Andy talk next as well. Do you have any other polling questions? I think that was it for the polling question. One more. Here we go. Here we go. On treating vitreous floaters, do you currently treat them? And this can be whether it's drops, whether it's vitrectomy, whether it's a YAG laser. It doesn't have to be only vitreolysis necessarily, but we'd love to see out there who is currently treating them in your practice, yes or no. All right, let's see the answers to that. So 50-50, okay.
50-50, wow.
All right, good. Okay, so we have 50-50 out there as well. Wonderful. I'm not sure if we have one last one, Brendan.
Exactly.
There we go. And then the last one here, we have, how are floaters treated? Here we go. This is what we talked about here earlier. You can do, you have no treatment right now, conservatively, which is just basically drops. There's some low dose atropine or other ways of helping reduce symptoms. YAG laser vitreolysis. We have vitrectomy, pars plana partial, like a core vitrectomy, or total vitrectomy. So please feel free to answer, and multiple choice is also acceptable.
Great questions.
Yeah. Okay, so few with the vitrectomy, mostly vitreolysis, and of course there's some that are drops and observing. So a good mix of variety of ways that people are treating and people who do treat and who don't. And one last question we have here coming up, I believe, is this one here. What do patients think about YAG? Interesting question here. If you currently use a YAG laser vitreolysis to treat floaters, how satisfied are your patients rather, with the results? This is a really good question. I'm curious to see what the audience says. So for those of you who are treating with YAG lasers.
And I think we'll touch upon this sort of as the webinar series goes on, really with respect to selecting the best candidates, and that kind of influences your patient satisfaction, of course.
Yeah, great point. All right. Let's see. Unsatisfied, 17%. This is very satisfied. Okay, so mostly satisfied. There's some that are moderately satisfied and some maybe not be. And that's a good point. Nathan just said here, it depends on patient selection, kind of what you're trying to achieve, the education, the expectation building of the type of photos they have. Will need more than one session. So that's a very good point. But Nathan, do you want to talk a little quick about what I think Ahmed had some really good points in his session and his lecture about really quality of life. And I'd love to ask you guys, all the whole panelists here, Ahmed as well. When we talk about kind of, I think, identifying patients who might be suffering or having quality of life issues, we tend to focus only on the chart, right? This, in America, 2020, so a Selling chart or 4-4, whatever it is, say 6-6. But the problem is sometimes it's not about the visual acuity on the chart. It's really about the contrast, about the distraction. Talk about that, maybe, you know, Nathan or Ahmed or Andy. What are your thoughts on how you assess quality of vision or patients' dissatisfaction with floaters?
Really,
Paul,
Yeah.
let me just very briefly start with a very brief answer, because it's actually my first slide, which I put in my presentation, saying
okay.
that traditionally we're focused over 20/20 vision and clear optical media and normal eye fundus, and that's it. And we say you're healthy, so why do you bother me, to our patients? And that's probably the biggest problem. So we need to change our perspective first, I guess.
Yeah. Nathan, what are your thoughts? I mean, something like a Weiss ring. I mean, what kind of quality of life issues do they have?
So it's very variable. I will say that, maybe as an early adopter to this technology, I don't necessarily focus on the visual acuity per se. It's all about the patient's story, what's really happening. I really just ask them, are you unable to function the way you are now? Is it interfering in your activities of daily living? And I find, there's a whole spectrum. As Ahmed pointed out, I have a patient that was on antidepressants. He got his laser. He's off antidepressants. So there's a spectrum, but I definitely use the patient's clinical story and their job and how it's impacting their life, and whether they've now quit driving, changed being an engineer, they can't be a pilot anymore, like some meaningful change in their life, to unanimously decide that this is an activity worth engaging in. Ahmed, what are your thoughts?
Ahmed, what are your thoughts?
Really, I ask the patient to draw what he's seeing. I'm not concerned with the acuity of vision, but definitely when the patient is drawing a lot of floaters in front of him and concentrating on one of them, this makes a sort of connection between me and him. I understand what's the real problem. So as I said, I'm not depending on the acuity or even the contrast, but what bothers the patient. So drawing the floaters is an essential point to know what we're going to treat and what is the patient suffering from.
Yeah, it's interesting. I had one of my first, probably maybe after my first 10 or 15 vitreolysis patients. I've done about 6,000 now in my career. I remember many years ago, after my first 5 or 6 or 10, I had a patient come in with a Weiss ring. And I was questioning the validity of their complaints. I said, Mrs. Smith, you have a small little Weiss ring. And I was thinking, are you sure it really distracts you, really affects your quality of life? And actually, she went up for me and she said, Doc, live with this. And she put her finger in front of my face and said, what if you had that in your face all day long, every day? Would you want that? And it shocked me, but it made me appreciate the fact that it doesn't affect our actual vision, its acuity, to look at that every day and have it distract you. We'd look at speed and others, but it really can impact quality of life. So I think that's a very, very important point. I want everyone out there to understand that, because a lot of times, as Andy and I, we've talked a lot about the studies that have been done in the past, when they've looked at outcomes, they've used as a definition of outcome visual acuity improvement. And so if you look at data on vitreolysis, you may say, oh, wow, it doesn't work very well. Well, because their outcome was visual acuity improvement, and that may not happen in some of these patients, depending where the floater is located. But conversely, you may have floaters that are right in the middle of the vitreous, right, an amorphous cloud in the middle of vitreous, and it can decrease contrast sensitivity, MTF curves. And we'll talk the next seminar with Andy, kind of HOA and aberrometry. But tell me about that in your experience, everybody in the panel. People, do they describe that they're able to see better contrast or quality, even if it's the same? Talk about the vitreous opacity in terms of its contrast sensitivity. How about you, Andy?
I think there's definitely
Go ahead, Nathan.
I think there's definitely an impairment, when we look at these patients. But I think something implicit to what you said, which triggered my mind here, is we are quick to immediately dismiss or second guess the patient's experience, because number one, we may not have that same floater in our eye, and we're used to treating visually debilitating diseases. But why is it really any different than a 20/20 unhappy cataract patient, right? Like there's something just off about their vision, just something that we need to tweak. We don't see why they're disturbed, but everybody's vision intelligence is quite different. So I think, there's always gains we see with these patients, but I think as we evolve this discussion today, we'll see that patient selection and technique and floater type and correlating all that is really key to getting as many home runs as possible.
Absolutely. And any comments about, in terms of just, we're going to talk about patient selection as well, but the ones that you've done mostly, are you doing mostly ones that are Weiss rings, or are you doing mostly clouds and strings? Just kind of comment briefly on kind of the ones that you're doing mostly, the type of patients.
wide strings are what respond perfectly, give the best results. So for the beginners, I advise them all the time to choose the small wide string in the middle of the vitreous, away from the retina, away from the lens, preferable pseudophakic and high myope. These are the criteria to start with to have a good satisfied vision. And all of the time be pessimistic, don't be an optimistic. If you think that the vision or the float will improve by 70 or 80%, I'm telling the patients about 60%, 65%. And this even when the patient feels that he's seeing better, that will be good for him. And again, never ever to give a fixed number of sessions. Maybe 3, maybe 4, maybe 2. It depends on the patient satisfaction. Floater shouldn't disappear totally, but what's satisfying the patient, that's more than enough for me. That's it.
And you mentioned earlier in your lecture about the distance from the retina and the significance in the patient's vision. Nathan and Andy, do you find that that's true, that when you have a patient who has a floater more close to the retina, that's more distinct, they can see it more defined, but then it's more anterior, it's more amorphous, more maybe cloud-like in their vision? Anyone want to comment on the location of the retina and its correlation with symptomology?
When it's anteriorly, it's less bothering the patient, but when it is in the mid and the posterior vitreous, it bothers the patient more. So the anterior floaters could be ignored, but the mid and the posterior floaters are difficult to be ignored.
Yeah, I think with experience, you can see that even very, very similar Y strings being within different distances from the retina give completely different symptoms to patients. And initially, when you start, you say like a Y string patient is perfect to start, and myopic patients as well in many cases. But then you realize that sometimes it's not a Y string, because there might be a Y string and a very small opacity just next to it. And you remove a Y string, you're very happy with the outcomes, and the patient says, "Doc, I still can see my floater, right?" And just because you were focused on something what was clearly seen by you, doesn't mean that you help the patient.
That's right. That's why I'm asking the patient to draw it.
Yeah, so, correlating signs and symptoms. That is a really, really important question, because you may see 3 or 4 or 5 different floaters, and the patient may complain of just one that they're bothered by. And so part of it, like you said, Ahmed, just saying, ask the patient, where does it come from? What size, what is the shape? Some of these patients are so acute, and they're so clearly able to describe their floaters to you that they can actually help you define which one of the floaters that you see might be clinically significant. Last question before we move on to Andy's talk, to everybody here. How many, do you feel that we have as a profession trained our patients to not complain of floaters? Meaning, are there some patients where you just they come in and you see a floater and you ask the patient, "Hey, does that bother you?" And they say, "Oh my God, doc, yes, but I thought nothing could be done." Has that happened to you a lot? Nathan, what do you think?
I think, yeah, I think as a science and as a community of ophthalmologists, the amount of dismissal up to this point has been significant, because we didn't really have a great solution. We had, the generation 1 YAG laser, which was in the hands of a few who did this type of work, but we don't see it or acknowledge it as a disease. And as we stated at the start of this, at the outset of this webinar, it is something that our more modern day population is definitely much more aware of and bothered by. So I think we have we've invested in the idea that this can be dismissed. And I think obviously in the select handful of patients that we do, that end up in our offices for this treatment and meet criteria, et cetera, the quality of life impact in and of itself speaks to that idea being wrong, that we should be actually looking at this in the right patients.
How about you, Andy? I mean, do you other patients where you the floater and they haven't really come out and said, "Hey, I'm having a hard time," but then once you ask a patient, "By the way, do you have floaters that bother you?" Then they say, "Oh yeah, doc, I do. I just thought nothing could be done." Has it happened to you, Andy?
Yeah.
Sure, that happens so many times, and what patients say is like, I've been to like 8 or 10 ophthalmologists, and all of them ignore that. They say, okay, you can live with it, and like 95% of people can live easily with the floaters, but it's not a solution, right? Sometimes talking about it, it is very important for your patient, because they know you feel that problem, that you see it, but you feel the way they feel. They perceive it in a very negative way. So that's a very important issue.
Yeah, I'm so glad you brought that up because, sorry, will you say something, Ahmed?
No.
Okay. I think it's important because sometimes just acknowledging it, right? Just as you mentioned, sometimes patients just want you to appreciate, yeah, I am suffering and I appreciate that you're suffering, Mrs. Smith. I may not do the procedure for you, but someone else may, but I understand that it's bothering you enough to warrant something to be done. And I think that's important. Number two is for my first probably 100 cases, I didn't go out there and try to get referrals. I would just ask patients in an exam room and say, hey, Mrs. Smith, I see a large floater in your vision. And many of them would say, oh my God, doc, I am bothered by that. But I'm like, why didn't you tell me? Well, because I thought nothing could be done. I was told many years ago nothing could be done. So they stopped complaining about it, even though it's still clinically significant for them because we trained them to stop talking about it. And so that was really interesting finding after doing more of these. I realized how many patients really may not be telling you in your practice. But if you ask about them, they really do tell you, they divulge that it is bothering them. But great discussion. We'll have some more discussion after each one of these talks. But to stay on time here, I think, Andy, you're next. So do you mind sharing your screen and your pre-record, if that's okay?
Yes, exactly.
Thank you.
Right. So hope you can see it well. I would say good afternoon normally, but for me it's a morning. So good morning and good afternoon to everyone here again. I'm very happy to talk about diagnostic aspects of floaters, and I guess we all need to understand that the floaters is like a bunch of different problems, different perceptions, different symptoms, which we still completely don't understand. And I had a long discussion with a group of Polish patients on Facebook within recent days, and just talking about specific ways they perceive floaters, and the way they describe it is so different. The way it's important for them is so different. So I guess the first thing we need to understand is that the floaters for many patients are a very important disease, and many of them cannot live with that. And that's why we're probably trying to focus on that. So during my presentation, I'll try to focus on very different topics, which will be discussed during our next webinar. And it's my warm invitation to join us on October 15th. Together with Paul, we're going to moderate this webinar and talk specifically about different types of diagnostic methods in diagnosing floaters. And let me very briefly summarize the role of those methods and how we perceive them as specialists, and in the same way, what can they give us in terms of perception of patient symptoms. Obviously, the clouds within the vitreous and the symptoms of patients, which are cloud-like, are acting exactly in the same way as the clouds in the sky, and that's why we need to understand that traditional ophthalmic approach doesn't really help us in understanding floater patients, because our traditional approach would be saying visual acuity 20/20 is perfect, optical media are clear, and eye fundus is normal. What for many of us means that the patient is healthy, but this patient is not happy from what the quality of vision is, and I guess that's the most important issue to find a way of properly documenting the symptoms of patients. So what patients can feel? They feel cloud-like symptoms depending on the type of clouds, obviously. But I think it's not just the perception of clouds. At the same time, obviously that depends on the conditions. And what is the worst condition for them is clear water, is blue sky, and very light days. So many of my patients mentioned the videos from Andrzej Kwiatkowski with 3D animations, and many of them say, this is exactly what I see. This is exactly what my visual symptoms are. So I strongly encourage you to visit this YouTube channel and see a couple of videos which are there, because that represents exactly what our patients are telling us. And when you see it, then maybe it's easier for you to percept what's the difference in quality of vision they experience. But obviously, it doesn't tell you all. So many of our patients are trying to forward the subjective perception of floaters to us by drawing floaters. And in many cases, it's probably not the best way of how we would approach the treatment. But at the same time, it's giving us the opportunity to understand whether it's just a perception of a single large floater or there are multiple points. And as we mentioned, sometimes it's not just a white ring which is in the center, which is clearly seen. Sometimes there are like very small spots next to it, and they might be an issue for our patients. So be careful. It doesn't always mean that the biggest floater is the issue for the patient. Sometimes drawing them helps a lot. Can we do more? That's, I guess, a very good question. And we're going to focus on that, looking at different types of imaging methods. Obviously, I would start from the ultrasound, as ultrasound diagnostic process was the first one for me to try to approach floater treatment. I was trying to measure distances from the retina. I was trying to find out what's the mobility of the floaters. Right now, I don't really think it's crucial for treatment, but for many beginners, that will be still the method of choice, which is cheap, very well accessible, and at the same time very easy to perform. So the traditional way to standardize floater examination would be before and after the treatment, and I guess it's very important to show it not just to yourself that you did well with the treatment, but at the same time, you can document it and show it to patients. Because sometimes when, especially when you start with floater treatment and your patients are unhappy with the outcomes, it's one of the ways to show them, look, this is how it was before. Right now, we don't really see those hyperechogenic shapes which were there before. So probably there are some small remnants of the initial floater, but it's not the same problem anymore. So we can extend the treatment, but we're going into the right direction. So what is very important in terms of understanding ultrasound technology is that the ultrasound gain should be set to maximum. That's one of the basic rules for documenting floaters. And sometimes correlating the drawings of patients with the ultrasound helps a lot in terms of understanding what can we do to treat specific floaters. Obviously, Y strings are the most spectacular floaters to consider, not just when you start with treatments, but to document it and to learn how to document floaters as well. And this is a beautiful image of a Y string from Dr. Adamski, who will be my co-presenter in October. And I guess if you have a high quality ultrasound probe and you're able to document the contrast, the distances, you can really prepare the patient well for potential treatment, and at the same time, better understand patient symptoms. Just as you can do it in this case when you try to go on with dynamic evaluation of the vitreous, not just to see the distances, but at the same time, see the mobility, see the location of the Y string or any other floater. Obviously, documenting the procedure, the treatment procedure itself is not something very common, but sometimes it tells you a lot about what's happening in the vitreous. And both Paul and myself, we did it before just to acknowledge other specialists, what's really going on there, how minimal is the movement of vitreous during YAG laser vitreolysis. And that's probably one of the reasons why we feel so confident regarding the outcomes and safety of this procedure. So we obviously can do the same for vitrectomy. It's much harder when it comes to documentation, but many patients who are looking for floater-only vitrectomy would be interested in finding out whether this procedure can be successful in removing floaters. But we know that in terms of the impact on the vitreous is completely different, and obviously it's like a small needle with vitreolysis, and a larger impact with vitrectomy. Obviously, there are patients who are excellent candidates to perform vitreolysis, and are absolutely excellent candidates to perform floater-only vitrectomy. So it would be reasonable to differentiate those patients at the time of diagnostic process. So obviously, we are dealing with different landscapes of vitreous opacities, and the ultrasound imaging of the vitreous would be probably one of the first approaches you would try in your career to help you decide whether the patient is suitable to do that. And I guess our October presentation and the extension, which will be made by Dr. Adamski, will help you in understanding that. So probably fundus photography is another very important method used by many specialists. And when it comes to the detailed, in-depth evaluation of the floaters, sometimes it's the best way to see not just the orientation or the distance, but at the same time the nature of specific floaters. So obviously, it's not just fundus photography, but the SLO examination helps us a lot. And still, this pretty old video of Professor Tassignon shows us in the excellent way how the central floater disturbs patient's visual function when it moves over the macular region. And I guess that helps a lot in understanding why the central symptoms do not affect visual acuity in so many patients, just because the patient can move the eye a little bit and still see 20/20. And unfortunately, in many patients, they say, okay, even if I can move my eye a little bit, it doesn't help me in terms of permanent stabilization of the quality of vision. So obviously, we have different types of floaters, and I guess when we look at them, obviously we are getting very familiar with Y-strings and myopic type floaters. But when it comes to central amorphic clouds, that would be probably one of the hardest approaches to YAG laser treatment. And in many of those patients, I would definitely consider vitrectomy if the patient is desperate to get any help with that. So it doesn't mean that if I'm doing YAG laser vitreolysis, I will be against performing vitrectomy. There are patients who are suitable candidates for both, and it depends on what's the extension of floaters. Obviously, smaller clouds and smaller opacities are excellent indication to perform vitreolysis treatment. When it comes to much larger structures, then we can consider vitrectomy then. When it comes to imaging of the vitreous, I really have to appreciate fantastic work and fantastic images taken by Dr. Karl Brasse, who would be another of our presenters in October, especially when it comes to myopic floaters, amorphous clouds, and vitreous trends, which can be sometimes not very easy to notice when you examine the vitreous. Dr. Brasse is doing a great job, and is trying to acknowledge us that it's really just the way you position the source of light to find out whether this floater can be significant for our patient. And it's probably one of the reasons why so many of us during eye fundus examination don't see the floaters. So it's a reminder. Try to use a coaxial illumination, but at the same time, try to use the light on the sides from time to time, just to see the cross-section of vitreous and maybe see more than just the central red reflex. When it comes to imaging and documentation of floaters, obviously correlating that with symptoms makes sense. So seeing shadows by patients obviously is correlated to the distance from specific floater to the retina. And that's why we heard it before, that so many floaters which are behind the lens or within the anterior part of the vitreous are not that much symptomatic as the floaters right in front of the retina or in the mid-vitreous. But that's another story. And another speaker who joined us in October, it would be Dr. Tess Hulin from China. And I guess he'll try to focus more on wide field images. And as you see here from his pictures, wide field images show us a lot in terms of nature of vitreous problems. Sometimes if we just focus on the central vitreous, we don't see that the peripheral degeneration of the vitreous might make us symptoms. And only if you ask patients to look downwards and straight toward the light a couple of times, then you see that there are a couple of floaters appearing from the bottom of the vitreous, and they would be actually damaging patients' visual quality. So obviously, correlation between color photography and ultrasound sometimes plays very important role in understanding patient symptoms and at the same time decision-making process regarding potential treatment. I'm a huge fan of Paul Singh's images showing the role of aberrometry, and at the same time, I think aberrometry is doing a great job, not just in patients who suffer from problems after premium IOL implantation, but patients who are suffering from floaters are one of the groups where we didn't have such excellent tools to document their quality of vision. So what's aberrometry can do for us? If you consider the eye trace aberrometer, which is using the ray tracing technique to see what's the impact of specific opacities within the optical pathway of the eye, then you can easily document what's the quality of vision before and after. And I would use a couple of slides from Paul. This is to show what's the quality of internal optics of the patient before the treatment. We see that the E letter is quite blurry, and actually when you perform the treatment, it's getting much easier to recognize. And at the same time, the dysfunctional lens index is improving a lot. We had slightly over 3 before, and right now it's 10. So it's showing up a dramatic increase of quality of vision and quality of light perception. So at the same time, it's reasonable to take a look at higher order aberrations just to recognize what's going on, whether it really helped us in what's happening to the perception of light in patients' eyes before the procedure and after it. So comparing these procedures, I mean the pre and post-op imaging is helping us a lot, not just in understanding the role of treatment, but at the same time, I guess it's helping out the patient to understand what happens in the visual process and how we improved it in such case. So obviously, it must help us in terms of reaching a very good optical quality, reducing higher order aberrations, and at the same time, many of our patients would be extremely happy to see that it's not just a subjective perception, but at the same time, it can be objectively measured. But I guess Paul will tell us more about the role of aberrometry, and I'm so happy that we'll be co-chairing the next webinar. So looking forward to our next discussion. And let's move forward to the OCT. It's probably not the first choice which we are considering in terms of what can be used for the diagnostic process. But I guess for many of us, OCT is very well accessible right now, and I guess it's not just to show what's the distance between the floater and the retina. It's not just to show the nature of the floater, but it's showing us a lot in terms of what is the patient perception and what can happen if the floater has a central location, like in this case. So I would appreciate the images from Dr. Adamski again to show you that the signal strength in such case can be even as low as 0, just because of the central floater. And after the floater treatment, you're getting very nice improvement, and at the same time you're able to see the pathology, seeing epiretinal membrane, and at the same time signal strength at the level of 7 gives us a lot of information regarding next steps and potential diagnosis of the patient. Obviously, diagnostic shadows are something what doesn't help us in many cases, especially in patients with macular problems or patients with glaucoma, when we have opacities right in front of the optic nerve. And when we're trying to evaluate the retinal nerve fiber layer, then we have significant problems in measuring it. So it's one of the arguments why the treatment in such cases should be considered, not just because of patient's perception, but sometimes because of diagnostic reasons, which may help us in this decision-making process in such patients. And obviously, we'll have another co-panelist in October that will be Professor Lagawa from Poland, telling us a lot about the use of the OCT in such case. However, it's not just the OCT use for decision-making process in floater treatment, but at the same time, the OCT and YAG laser have a lot of things in common, especially for cases like this. You can see the sub-ILM hemorrhage here in a very young 20-plus-year-old patient with radical loss of visual acuity. This patient could see HM, and I was able to treat him with very good result. That's only 10 minutes after the treatment, and reaching finally 20/20 vision without any further intervention. So it was just a couple of minutes to treat the patient, receiving very good response. So to summarize, I guess considering different options for objectively documenting floaters is very important when you consider treatment. It's not just for medical reasons, but at the same time, you have to consider legal reasons, because many colleagues, many doctors are against any treatment procedures in vitreous floaters. So it's really important to document them well before you start any treatment. Ultrasound OCT right now are very easy to use. In such cases, it doesn't tell us that they are crucial to understand the nature of floaters, but for sure that they help us a lot. However, I think that's what is really objective in terms of understanding floaters would be more likely to be aberrometry and not the traditional diagnostic methods which we have. So probably in many patients, we will just use a combination of different methods, and that would give us a lot to understand the patient perspective. So again, please be so kind to join us in October, and let's talk and let's discuss different methods in floater diagnostic process. And I hope you'll spend that afternoon in October with us. Thank you so much.
Thank you, Andre. Great talk. We'll have our panel join back. So that was a great talk on looking at a variety of imaging approaches to diagnosing and following vitreous opacities. Andre, question for you. You know, when you're going through this process with your patients, do you find that your vitreous opacity patients take more time of your clinic time or your chair time than other patients? And how do you manage that?
Oh, that's a very good question. You need to be prepared, especially if you see that patient for the first time. First, to spend a lot of time on talking to the patient, to understand their perception. Second, to spend more time on the diagnostic process. And I cannot imagine working with floated patients without it. So it's definitely not a very easy cataract patient where visual acuity and cross-section of the lens is telling you everything. It's not the same.
So, and Dr. Ahmed, what do you find? Do you find that these patients also take generally more time, or you take additional steps with them?
Yes, sure. The patient's counseling is an essential step, especially for those with floaters. And one of the best tools to prove for the patient the improvement is the ray tracing, as Andre described. Really, eye tracing is very nice to show him what he's seeing now. And then he says, yes, doctor, I'm seeing exactly the E like this, whether in the cataract or in the vitreous floaters. And when the patient improves after the vitreolysis, the difference really makes a big difference for the patient. So we have to spend more time. We have to show him some of the pictures before and after for other patients. So it's a good way to deal with the patient and to discuss with him the ways of treatment.
Paul, you've got 6,000 cases under your belt, which is a lot, I would say, for this particular technology. You know, how do you keep this sort of streamlined in your practice? Because for those of our, you know, attendees that are looking to sort of venture into the space, one of the parts that they'll probably want to be concerned about outside of all the medical, legal, patient selection is, how do I keep my flow?
Yeah, it's a great question. I think the key is, for me, is to not do them in the middle of a day. I have certain block times, let's say in the morning or in the afternoon after my clinic. I'll have a couple hours where I'll have my vitreolysis patients set up in a row. And I have a few trained technicians who are very well versed on how to kind of get the patients through the door. You know, I think as you get more comfortable, as I'm going to talk about with my next lecture, as you get more comfortable identifying the floater in the procedure room, the number of shots you do, you're much faster at feeling comfortable firing the laser. At first, you're like, you fire a shot, and you look around, did I blow up anything? Is everything okay? Second shot, okay. And you're taking 25 minutes just to get the good view. But once you feel comfortable obtaining a good view, achieving that comfort level of spatial awareness, where am I in the vitreous, then it becomes more efficient. And so it is something that just takes some time. But I think the key is identifying the patients quickly in the exam room lane, but not doing it that same day or doing it in the middle of a day, giving yourself block times.
Can I make a little comment on,
yes.
on Andre's presentation? Well, you showed the video on OCT, on SLO, sorry, and Nathan will also speak about it, I guess. But I think the most interesting thing about that SLO images is that you also see the degree of movement, which corresponds, in fact, with the degree of liquefaction of your vitreous. And I would love to work with a physicist who can transfer the movement and the speed with which the floater changes in position in order to try to get an idea about the liquefaction of the vitreous. Because that is another parameter that is extremely important when treating with patients with floaters. When you have a very liquefied vitreous, you just push it back, and it floats everywhere because of the liquefaction. And that is, of course, also very important to know in the beginning on whether you have to increase your energy, because the more it moves, the more higher your energy will be in order to catch the floater. Well, thank you for showing that video. It's an old one. It's an old one, but it is.
Yeah, it is. But I think if you remember the video which I showed from YouTube in the beginning of my presentation, there is such a high correlation between the way patients see and what SLO is showing us. And if we can manage to automate the way SLO works together with the treatment process, that will be probably an excellent way of solving problems.
Yeah.
Yeah, I mean, there's a lot of new technologies working on kind of different imaging technology, different companies out there working on that. So I think we're going to see more advancements. But a couple of points on the OCT as well. You know, we published a paper in OSLI a few years ago looking at the shadow, as you showed earlier. And I think that's an important concept. We had patients who came in who had diagnostic testing, FAs, MRIs, because of scotomas that were in their vision. And no doctor could understand why. Well, it was as simple as a floater causing that shadow, and you could see that shadow clearly over the macula as well. So I think, and to your point, Marie, about the floaters and liquefaction, sometimes you can use the movement of the floaters to your advantage. If the floater is right over the macula and too close, you don't feel comfortable, sometimes I'll move the eye up and down like this, and you'll cause a current for the floater to come forward and come around, and it'll give you a better chance of firing in a safer zone. So you can use the liquefaction and the movement to your advantage. And that's part of the learning curve, as I'll talk to you briefly about in my next talk.
But that's for the treatment aspects, yeah.
Yeah.
It's really a dynamic process. And I guess, a question for the panel, and we can start with Andre, is what's your endpoint? How do you determine when you're done?
You mean with treatment, right?
Yeah.
That's another fantastic question, because sometimes I feel I'm very happy with the outcome, and the patient is calling me like a week later or 2 weeks later and is saying, "Doc, there's no change. I don't see any change," right? And sometimes it's like I'm just lost, and at the end of treatment I'm saying like, "Come on, I didn't do anything," and the patient is calling me on the next day saying it's a fantastic outcome. So sometimes we don't really understand whether we did it correctly or we didn't do it correctly, right? So it's really hard to tell whether the treatment process is finished. And that's why I'm always telling my patients, look, especially after young lazy vitrolisis, wait for the first week, because you're going to see a lot of debris for the first couple of days. But generally, I would evaluate the final outcome after like 4 weeks. And after that time, if you feel we haven't solved the problem, you should either schedule another appointment or just let me know, right? So it wouldn't be based on my perception. It's based on patient's perception.
Dr. Ahmed, what's your process on how to determine when you're done?
Again, it's a very nice question, because you cannot fix an endpoint for all patients. You don't have a cut-off endpoint. So first of all, I'm giving the patients sessions on a weekly basis. There's a difference of 7 days between each visit, yes. And this allows him to re-evaluate his situation. I don't fix a certain number of sessions or number of shots. And again, I'm asking the patient, especially after 48 hours after the effect of the mydriasis vanish, to assess the situation of his floaters, and to send a message for me, whether he improved or he didn't improve, or 10%. As I told you before, I never fix number of sessions for every patient. So some patients, after the first session, they say that we are satisfied. It's more than 60% improvement. And astonishingly, after the second session, he says, I don't feel that improvement like the first session. So that's why it depends on the patient's personality and the patient's need. If the patient says, I'm satisfied with this, I stop. I'm not looking that I have to liquefy all the floaters to be sure 100% everything is clear. No, never, ever. I'm asking the patient depending on his satisfaction. Once he's satisfied, I stop treatment. That's it.
Marie, do you have any comments about sort of how you determine your endpoint? Maybe while she's
getting back here, yes, thank you. Well, just the same than Ahmed. I think that it is sometimes also I'm surprised that the patient said, you know, I'm very fine with the result, I'm happy. And I thought, oh, I think that case will need a second session. So it is very different. It is very strange. We do not understand everything about the patient's complaints still. Images and whatsoever up till now, well, they have their restrictions. And yeah, we need to, that's the reason we need research, and that's the reason we have a third webinar in December. And also that I invite everybody to come and join us, because I think that it is really exciting to have some research about that.
And I will say one comment about the end. Everyone's, you can't give 100% guarantee what the endpoint will be. Most of the time, a white ring is the endpoint can typically be, very commonly, resolution, your visual resolution. So you'll fire, you'll see it break up into small pieces, and there'll be more vaporization, you'll go for those smaller pieces. But the end result, a lot of times, is resolution of that opacity. But if there's multiple strings and clouds, then it becomes very difficult to know what the endpoint is. It's either how comfortable you feel, the patient gets uncomfortable, And the more number of shots, there's a risk potentially in some patients of the pressure going up, which we'll talk about as well. So there's some variability there, but the Weissring patients tend to have more of a clear endpoint.
All right, I think with that, we should turn it over to Dr. Paul Singh, who's going to take us to our next talk. And 6,000 cases a lot. Love to hear what you have to say about it.
First of all, great presentations to everybody. I appreciate the impact that, we've talked about impact of floaters on quality of life. I will try to fast forward through some of these to make it time constraints as well. But I do speak and consult for Quantel LX, which is one of the lasers I use for my laser vitreolysis from Wisconsin. So if you ever come to Wisconsin, come to the United States, come join us. We love our beer, our cheese, our lakes, our American football, but it's really cold in the winter. So please come in the summertime right now. I'm also in a band called Funkadesi, which is funk and reggae music. So it's my escape from ophthalmology world, and it's really allowed me to see what binds us, what the commonality we have between us versus what separates us. So it's been a way to kind of help with my patients to see what we all have in common. I'm going to fast forward to this, but I just want to make sure that we address this again one more time. I cannot overemphasize how important it is to appreciate how much of an impact floaters have on quality of life. And we've already spoken about this earlier as well. And Ahmed talked about the American Journal of Ophthalmology, this study that was published showing patients are willing to risk more than even HIV, diabetic retinopathy, and even certain cancers. And about 7 in 10 people will have a significant floater in their life at some point in time. Out of those, about 30% will be clinically significant. So it's a common problem. But there are a lot of skeptics out there, and I understand why, especially with YAG vitreolysis. First of all, fear of complications. Are you going to blow up the eye? It's a fear that people have. Does it really work? Some of the earlier studies that have been done have shown us that maybe it doesn't work as well. And that's because of the endpoints that they use, like I said, visual acuity, the energy levels that some of them are using in the past for studies were 1 or 2 millijoules. As we'll talk about, we'll go to 4 or 5 millijoules oftentimes, a higher energy to create that vaporization. Also, we've had YAG lasers for years. So why all of a sudden now do we see this significant excitement over vitreolysis? And so we'll talk about what the technology has done and what it's changed to allow us to feel more comfortable and safe performing it. And lastly, do we feel there's a value to treating? If you as a surgeon do not feel that a pathology is worth treating, then you're not willing to risk anything, right? So our risk-benefit ratio depends on how much we feel that pathology is worth treating as well. And as we mentioned earlier, as Nathan mentioned earlier, a cataract, right? We can't compare our technologies of a vitrectomy or cataract surgery. And this is a picture of Charlie Kelman's early Cavitron phaco machine. Well, there was a high risk issue with those. And so we waited until patients had very advanced cataracts, just like vitrectomy. But now with technology advanced, our safety has gone up. Our then definition of the clinically significant floaters has changed over time as well. And again, now we don't wait till a cataract is ripe. A 20/25, 20/30, 20/40 cataract is now a worthwhile treatment, a surgical option or candidate because of the safety of cataract surgery as well. So something that definitely has changed. And I want to make sure we're clear that vitreolysis is not a replacement. This is not a competition for vitrectomy at all. Vitrectomy has its place. And I'm not a vitrectomy surgeon. I don't do that. I do send them out. There are patients who have multiple floaters, strings and clouds, asteroid hyalinosis, as Ahmed mentioned earlier. They're a better vitrectomy candidate, just like we have in glaucoma, my specialty. We have SLT, we have MIGS, and we have trabeculectomies. We have a range of options depending on severity and risk tolerance. But the vitrectomy is a great option. A lot of the patients for vitreolysis specifically are patients who are not good candidates for vitrectomy. For instance, I've had patients who come to my office who are seen a vitreoretinal surgeon who've said, hey, you have a Weissring, you're phakic, you're 55. It's not worth doing a vitrectomy at this stage. They'll send them to me for a vitreolysis. And conversely, if I have someone who has strings and clouds everywhere and they're pseudophakic, it may be a better vitrectomy candidate. So they work together. It's not one or the other necessarily, as Andy mentioned. But what do we need for vitreolysis? What are the key components? Well, you need a laser, of course. And I think one of the newer lasers that are out there, which I'll share with you, that have different coaxial illumination type of technologies to allow us to visualize. Visualization is probably the biggest and most important learning curve, important, I think, advancement that we've had in technology to allow us to see those floaters. We have different lenses. I have no financial interest. As a lens I help Volk make, which helps us view all the way from the lens to the retina. And there are typical antiseptics and dilating drops, as well as our coupling agents. So not a lot of new things you need, except for the laser. Now, there are multiple companies that make these call coaxial type illumination lasers. I use a company called LX and Quantel. There's Luminous, there's Nidec, there's Lightmed. There's a number of different laser companies who are trying to create a new visualization system, this coaxial illumination. And so why is this so important? If you think about traditional YAG lasers initially were really developed so we could do capsulotomies and laser peripheral iridotomies. And all we cared about was looking at the capsule, nothing behind that. So the way YAG lasers were designed was with an off-axis or a non-coaxial illumination tower, where the illumination tower is coming from below and the oculars in your aiming beam are coming from a different optical pathway. Now they converge at the here at the posterior capsule. What if you have a floater on the right here? If you have a floater on the right, it's more in the middle or posterior vitreous, but you're crisscrossing your illumination tower and your aiming beam and your oculars, you don't see the floater. So a lot of the floaters that we want to treat, we just can't visualize with traditional YAG lasers. That's why coaxial illumination is so important. Now the mirror I use is something called a flipping mirror system, where the mirror goes out of the way when it fires. That allows you to keep the illumination tower, the aiming beam, your oculars, and the laser all on the same optical pathway. So that way you can see all the way to the retina and back, basically giving you full coaxial illumination, full view of the entire vitreous cavity. So it's called coaxial illumination. Now with coaxial illumination, by having all the light going through the lens into the retina, you can actually move the slit lamp oblique back and forth. By moving the slit lamp oblique, you can change the amount of illumination to give yourself different contrast. As Andy mentioned, as Carl Braz has shown with his beautiful photography, when you move the slit lamp oblique and give a cross section of the vitreous, you can identify better contrast of the floater, and you can still have enough illumination to see where the retina is. And I'll show you some videos that describe that technique as well, which is really important. The other technology to achieve coaxial type of illumination, which other lasers have, is something called a split mirror system, where there's two mirrors that converge the light to the retina to give ourselves that coaxial type of illumination. Again, the key is to see more than just beyond the posterior capsule. That is the key. And what I mean by off-axis or moving the slit lamp oblique is when you move the slit lamp oblique, that's what I mean by that. Now that does change the type of illumination. On the right, if I'm coaxial in the middle, red reflex. If I move the slit lamp oblique, I lose that red reflex. So the more anterior the floater is, the more I'll move my slit lamp oblique to give myself that better contrast as well. I'm just gonna fast forward to this for the sake of time. So here's some videos sharing and kind of showing you and demonstrating what it looks like in the actual treatment procedure itself. The key is to find the floater. So here's a Weiss ring. You see the Weiss ring there beautifully. And what I'm going to show you is there's the Weiss ring, nice and clear. Now the retina, the retina is further back. See, the retina is in focus. I go all the way back to the retina. Now I'm going to come back anteriorly to my floater. Now there's the floater. Now the floater is now in focus and the retina is out of focus. So I always go all the way to the retina and then come back to the floater to always give myself that spatial awareness. Where am I in the vitreous? Now that I know that I'm in the vitreous, the floater's in focus, the retina is out of focus, I know I'm at least 3 or 4 millimeters behind the limbus, or in front of the limbus, the retina, I have enough safety to fire. Now when I fire, you're gonna see it does move around a little bit there. Two things happen. We're causing plasma, which means you're seeing those gas bubbles form. So solid to gaseous state. We are vaporizing, but we're also breaking, we're fractionating. What that means is we're breaking the floater up and we're not gonna stop after a few shots like a YAG capsulotomy. We're gonna keep going, we're gonna keep firing until we see that floater start to dissolve or vaporize in our visualization, right? So that's the difference between a YAG capsulotomy and a floater treatment. We're not stopping at 10, 20, 30 shots. We're going to 200, 300, 400 shots oftentimes for these Weiss rings. And they do break, but we go for the smaller pieces to vaporize because the vaporization is occurring in a very small amount, microns. And so that's why they keep going and keep vaporizing, keep breaking. Now, as Marie mentioned, the more liquefied the vitreous, the more synoretic the vitreous is, the more likelihood you'll have it move around. But it's also important, the higher the energy, the more efficient the laser, the more concentrated the laser energy is, the more it stays close to where you fire. And you see here, the floater is pretty much gone. I see some small remnants. In our data, even if you have a small remnant and the patient goes home, in our data sets, if they still complain of a small piece of floater floating around, 80% of those patients will neuroadapt to the small remnants. So even if you have a Weiss ring and you have a small piece that's left behind, majority of patients can neuroadapt to those as well. Here's another example of a small, kind of a smaller Weiss ring, a little P there. That can be significant for some of these patients. Now I'm going to show you coaxial. I'm right now 100% coaxial. I can see the floater, but when I move the slit lamp oblique, I can't see it. So I went back to coaxial. I went all the way to the retina. I went all the way back to my lens, and now I'm back to the floater. So I'm always giving myself an awareness, spatial context. Where am I? Now I know I'm in the middle of the vitreous, away from the retina. I don't see any retina vessels. I'm fully coaxial here, and I can see that floater. I can start to break, vaporize. So refractionating, breaking and vaporizing. That's the difference between a YAG capsulotomy. You're going to keep going as much as you can until you see that vaporization occurring, until you don't see that floater anymore. But it's real time, and it's very rewarding for the most part to see these things kind of break apart and vaporize in front of you as well. So you have a clear endpoint for a lot of those Weiss rings. Fast forward for the sake of time here, just another Weiss ring showing you the same idea. But let me show you how you can also, though, protect yourself, not just from hitting the retina too far back, but what about the phakic lens? About 50% of my patients, if not more, are phakic. But you have to use the ability to move that slit lamp to give you a spatial context of where the posterior capsule is as well. So here's a video of a nice amorphous cloud in the middle, anterior middle vitreous. And it's a little bit closer to the lens, but I can't see the floater very well. I'm like, wait, where's the floater? Where's the capsule? It's hard to see. So I'm gonna move it oblique. And what I just did there by moving oblique, by moving the slit lamp to the side, I got rid of that coaxial illumination, but now I've been able to highlight that floater. Now it's like nice and white in a black background. And I can also, I'll show you in a second, see where the posterior capsule is better. So I'm gonna fire, but I'm gonna say, let me make sure I know where the posterior capsule is. So I'm gonna go ahead and move anteriorly. There's the capsule. Now I'm gonna move now, march, oops, sorry about that. I'm gonna march back here. So I'm gonna move to the anterior capsule. And then when I move to the anterior capsule, I know where that is. You'll see here in a second. Okay, I march back to the floater there. So what I've done is seen where the capsule is. Now I've gone back to the floater. This distance between the capsule here and the floater here is analogous to what we do when we're looking at, let's say, an anterior chamber depth. When we look at AC depth, we look at the endothelium of the cornea. We look at the iris and we see, okay, that's about 3 millimeters. The same thing I'm doing here. I'm looking at the capsule. I'm looking at the floater, and I'm saying this is at least an AC depth, if not more. I know about 3 or 4, if not more distance between the lens and the floater. So I have enough safety to fire. And that's, I think, an important tool to protect yourself from hitting the lens, to know where you are in the vitreous. Again, the key to safety is knowing where you are at all times. It's not the laser firing aberrantly. It's us firing in tissue that we should not fire in. So if you know that you're in the middle of vitreous, you can feel safe. Now, these amorphous clouds, they take more shots, more number of sessions. They don't break apart as quickly and easily as a Weiss ring, but these amorphous solitary clouds can be still treatable with a YAG laser. It may take 2 or 3 or more sessions, but you can get to those treatments very well. Another example of titrating illumination, what I showed you earlier was coaxial, and the last video was off axis or oblique. But now sometimes you want to go somewhere in the middle. You need some coaxial illumination, but not so much where it's too much of a glare. So I'm going to show you a video where I'm here in my slit lamp. On the left is me and the slit lamp, or my laser, and on the right is my view, split screen. Now you see there's a Weiss ring, and I'm far away from the retina. There's the retina, and there is the floater. So I know I'm far enough away because the retina vessels are obscured. That means I'm safe enough to fire. If I move the slit lamp oblique, I can remove some of that anterior glare to give myself better contrast. If I move the slit lamp too far away, I can't see. I need some coaxial illumination. Now to show you the impact of coaxial, as I bring it back to the middle, the slit lamp to the middle, I'm bringing back coaxial illumination. There's still too much glare. So let me move it 5 or 10 degrees oblique. Now I have the perfect amount of coaxial illumination. I've taken away some of it, but I have enough to know where I am. So now I know I'm in the middle of vitreous. I can see the floater nice and clearly. With moving that slit lamp oblique, getting rid of some of the extra glare, I can start to fire. And by the way, those gas bubbles they're actually going up in the eye, which means it's going down in their vision. So people say, Doc, I see all these things coming down in my vision. That's the gas bubbles from the plasma creation. Just another quick video here showing you coaxial and then titratable illumination. I'm going to go ahead and see there's a floater. If I can't see it if I go too far back. I can't see the retina. So if I go coaxial, I can see there's a floater, but it's too much glare. So let me move the slit lamp about 5 or 10 degrees oblique just to give myself less glare. But I leave some coaxial so I can go all the way back to the retina. And there's the retina. There's the floater. So now I've given myself, again, spatial context. There's the lens. So I've given myself the ability to feel comfortable firing as well. So that's why it's so important. Multifocal lenses are also important to know. We have a study that we're about to get published here showing us improvement not only in HOA from the aberrometry, but showing even improvement in reading. J1, J2. We had patients who were J3, J4, even J5 with these large amorphous clouds in the middle of the vitreous. With multifocality, it can decrease the contrast and the quality of vision. And we've actually seen a significant improvement in not only quality of vision, but also reading ability as well in these multifocals. So I just want you to know, you still can fire through a multifocal lens. If you're in a periphery of the lens and not in the center optic, you lose the efficiency because one of the YAG laser energies, one of the beams gets cut off and you don't get a good plasma creation, but it doesn't aberrantly fire, so it's not dangerous to fire with those as well. Let me just show you this video here real quick and I'll move on. I was talking to you earlier about how to move the floater in position. Sometimes the floater is not in a perfect position, so you can actually move the eye up and down to move it into position here. I'll show you in a second. As I move down and up, the floater comes more, there we go. Now it's coming more in front, and I can go ahead and fire. So if it moves back towards the retina, I can move the eye down and up, and it'll move it forward and more to the center, and I can fire it. So you can manipulate these floaters to a better position as well. All righty, just for the sake of time, I want to talk about energy real quick here and explain how we understand the safety profile, because one of the biggest fears I find from a lot of colleagues, Paul, I'm going to blow up the eye. You're going to cause a detachment. You're going to cause a significant inflammation. Let's explain why we don't see that and what's happening to actual laser energy. When you fire a laser, in a laser, we create something called a convergence zone we'll talk about. But important to understand that the actual pulse is about a 3 nanosecond pulse, about 4 nanoseconds by the time it gets to the vitreous. And the heat and energy is dissipated before the next shot is fired. So we're not seeing an accumulation, in vitro at least, an accumulation of heat. And what is this convergence zone? When you fire a laser, it's causing an acoustic wave of energy, a plasma shield, so to speak. That plasma shield prevents further posterior propagation of energy. So the energy will form, it'll stop on its own, and then the energy will come back towards you. The distance between this left side here and the furthest posterior area, this acoustic wave, is something called the convergence zone or the shock wave. An important concept to understand, in vitro at least, is that there's a nonlinear relationship between how much energy on the laser that you input, like 2, 3, 4, 5 millijoules, and how much dispersion of energy, how much shock wave or convergence zone. So in liquid interface here in vitro, you see at 1 millijoules, the shock wave is about 110 microns. If you go to about 10 millijoules, a 10 times increase in energy, the shock wave only increases to 210 microns. So not even 50% increase in shock wave with a 10 times increase in energy. This is why we feel comfortable firing at 4 or 5 millijoules, 6 millijoules, because we see this nonlinear relationship with shock wave. Here's an example. Andy showed his great view of his B scan. Here's another B scan showing you how little movement is occurring behind this opacity here. Now you're gonna see a bunch of white lines. That's artifact from the sound of the clicking of the buttons. This is the ultrasound here. But you're gonna see how little movement is occurring. This is at 6 millijoules. I'm not seeing any movement of vitreous, even a millimeter behind that opacity as well. So we're seeing the vitreous is fairly quiet, not seeing pulling and tugging like we see with the vitrector. And this is Andy's video I was going to share, but he already showed you that already. So I'll fast forward to this video, but again, showing no movement of the posterior hyaloid face when you fire the energy of the laser as well. So again, the vitreous is fairly quiet back here as he starts to fire. We're not seeing a significant pulling or tugging, which is important. To show this, here was a video of a patient who came from England. And she really wanted me to do her treatments. And I was very nervous because, as you'll see in a second, the floaters are really close to the posterior capsule. And I'm thinking, do I fire? Do I not? I'm not sure. And so you can see how close the floaters are. This is the capsule, that yellow there. These are the floaters back here. We're talking about a millimeter or less of distance. I put 100 micron offset. I focused a little bit posteriorly, and then I used about 5.5 millijoules, so pretty high amount of power. But you see how the spark is at 5.5 millijoules. We're not seeing a large explosion. We didn't hit the capsule. Now, I'm not recommending all those new users to do this, but it's just showing you how efficient the energy delivery is with these procedures and with this new technology that we have with these new lasers. And for the last 4 minutes here, I'm just going to share with you some data sets and some pearls on kind of what patients to pick as well. In our data set that we presented at 2016 ASCRS, this is our original 362 patients we did many, many years ago. About 93% of patients said yes, it made a difference. And after one session, about a 70% improvement, about 90% improvement after multiple sessions. Weiss rings took an average of 1.3 sessions. So majority of Weiss ring patients with one session, they're pretty happy. With amorphous clouds, sometimes 3, 4, even 5 sessions. For white rings, about 200 to 300 shots. For amorphous clouds, I was in the 500 or 600 shot range, just because it takes more shots to vaporize and break up. Our average power setting is about 5 millijoules. I'll start about 3 to 4 if it's anterior behind the lens, maybe go up to 5 or 6 more posteriorly. But again, it just depends on the behavior of the floater, and you can titrate your power depending on the efficacy of what's happening in real time. I did hit a retina in my early career. I've hit 2 now my total career out of the 6,000 I've done. Very rare, but it can happen. I'll show you a video. We have not seen inflammation. We haven't seen detachment significantly. We have had 1 detachment, and that was a combination capsulotomy and vitreolysis at the same time. When you're doing a capsulotomy and you break that capsule, where do the forces go? They go towards the periphery, right? The zonules are attached to the vitreous base. When you're firing vitreolysis, you're firing and severing strands of vitreous. You're not pulling against anything directly. So theoretically, we shouldn't see any higher risk of a detachment than even a capsulotomy. So we should see even less potentially from a physiologic perspective. I have hit 2 lenses before I understood how to move that slit lamp oblique. And I've seen pressure spikes in my career, especially if the floaters are too close to the lens and we do a lot of shots. We think the remnants rather of the floaters, the particles, may float in the anterior chamber and may block the TM, like a pseudoexfoliation type of condition as well. So it is something that can happen very rarely, but I have seen pressure spikes over time. So I do check the pressure at a few weeks out. And if there's a glaucoma patient, I do keep them on drops and check them within a few days just to make sure there's no pressure spikes, just to be safe as well. I did a larger study in 2017, a retrospective of over 1,200 cases. Again, same principle here, no new adverse events seen, no exacerbation of diabetic retinopathy, VMTs, we did not see any more CME, et cetera. And so I want to just recommend that you do your own data analysis, but we have not seen a significant increase in adverse events. Pressure spikes were the only thing that happened that we saw routinely here and there. This is the 2 lenses I've hit in my career. On the left, it was in the periphery. It has not progressed over the last almost 10 years now. On the right, the patient had some significant symptoms of glare after the procedures, those stellate-looking opacities, and I went ahead and did cataract surgery. I actually did a little bit of anterior vitrectomy and did a sulcus lens, did more vitreolysis afterwards. She was happy, but that is something that can happen, so you got to be careful. And hitting the retina, here's where I hit the retina. Why? Because there's a small opacity here. You can barely see a line here of a rope-like floater. Now look at how in focus the retina is. If you see the retina this far in focus and the floater is also in focus at the same time, this is something you do not want to do. So I was trying to be a hero. This is my probably 15th case many, many years ago. And I was like, okay, I can go for this thing. Now this is the nasal retina away from the macula and the fovea, but it still is scary when it happens. And I'll show you here in a second as I start to fire. I fired. My aiming beams aren't even focused on the floater during the retina. You see a white dot? That was me hitting the retina. After about a minute or 2 or so, I waited. You got a small round circle. You'll see here in a second. I'm just going to show you. There's a round red spot. After about 5 minutes of waiting and compression, that's the biggest it got. And it went away after a few months, and it had patient no visual defects. But it was scary for me. But again, how in focus the retina was, that was the problem. So last 3 slides here, and I promise I'll stop everybody. Sorry about this, a lot I know I want to talk about. But the bottom line is if you want to start, I think it's important to recognize the importance of how to do the exam. As Andy mentioned, the clinical exam is still so important. I look at this, number 1, can I see a floater? Can I correlate that with patient symptomology? Number 2 is where's the location? Is it too close to the lens, too close to the retina? I don't want to fire if it's too close. It's not worth it. Tell the patient to come back. Then I look at the density, the size, and the type of floater. If it's a rope cloud-like floater, I have to manage the expectations to a patient. This may take 2 or 3 sessions. Don't worry, let's give us at least 2 or 3 sessions. Then we'll decide if it's worth doing more later on. So it's important to look at those parameters. How to judge how far it is from the lens? I use an oblique illumination tower, and this is one on the left. Those floaters, those strings, too close to the lens, and the too string-like, it's not worth to do the laser for this patient, especially if you're starting out. The one in the middle here, you have about 2 or 3 millimeters away, but again, there's a lot of strings here. So for those new surgeons thinking about vitreolysis, this may take a lot of sessions, but I have done these kind of patients. But there again, this is about 2 millimeters, very close, be careful. On the right is someone where you feel like you can do. These are about 4 to 5 millimeters away at least. And you can see here, even though they're string-like floaters, they're more consolidated, they're more clumped together. The more clumped together these floaters are, the better it absorbs the energy, like a white string as well. Ahmed mentioned being able to have them draw it. I agree with Ahmed. I think it's important. We have something called a floater finder, which is like has a little light source and an Amsler grid where the patients can draw it on an Amsler grid and explain to you which one are they bothered by. So when you ask symptoms, they can tell you, here's what it looks like, here's where it comes from. Then you can try to isolate that specific floater when you're treating it. Don't treat patients if they had a PVD suddenly. I wait at least 3 or 4 months, as Ahmed mentioned, let them neuroadapt and also recheck the retina to be safe. Make sure that you have someone who can stay at the slit lamp. I use have my technician hold the head still, and make sure you have a nice palpebral fissure so you can put that lens in the eye without the patient squeezing. These are small, fit, simple things. If a patient comes in with a drawing on the right like that, where they're telling you, I have 150 floaters everywhere, that's a vitrectomy candidate or an engineer, not worth doing it as well. Let me just fast forward for the sake of time here. A couple more pearls here. If you are starting out, and Ahmed mentioned, how do you, or I think Nathan asked, how do I manage efficiency and flow? I don't schedule in the middle of the day. Give yourself initially about 15, 20 minutes to get comfortable viewing the floater, giving yourself an understanding of where the floater is and safety, and then starting to fire. Having the technician hold the head still is important. And if I'm doing only one eye, not the other eye, I anesthetize the other eye, even if I'm not doing it, so they don't get dry and irritated trying to keep both eyes open as well. They may see dark black for a few minutes after because of all the flashes of light. That goes away very quickly. And they may see gas bubbles right after the procedure, like little spots because of the particles of gas from plasma. Again, there's a lot to talk about, but this is kind of an overview. The key findings, the key factors, though, I think, for the most part, are really, number one, being able to view the floater. Number two, understanding where you are in the vitreous. Those two are the biggest learning curves from a procedure perspective that allow you to feel comfortable and safe to do the procedure as well. But I hope that helps you. I'll stop sharing so we can have a quick discussion. I know I went over a little bit there, but I hope that helped give you some understanding of what the procedure looks like, some of the key pearls of safety, and some of the new technologies with coaxial illumination that has helped us feel comfortable performing the procedure. All right, guys. Sorry, I went
great
over
talk, Paul.
Apologize.
No, that's great. That's great. I think really comprehensive and 360 in terms of approach and the subtle techniques. I think a lot of us are used to obviously putting things coaxial just in general with our slit lamp techniques, but it's never been articulated this way in the context of floater. So that's really appreciated. Thank you for that, Paul.
Sure.
So question for you. You mentioned offset, and I think those of us that are using the LX laser have that option to offset what your offset level should be at, and maybe describe what offset is for the audience that may not have that feature.
Sure. On the LX laser, I think some of the other lasers too, you can actually use what we call an offset, posterior or anterior. So you can set it where that your aiming beam will be where we put it, but the laser will fire 100, 200, 300, 400, 500 microns, depending on how far of an offset you put it. So let's say you're seeing a floater posteriorly. To help with what we call parallax and to help from safety, you can do an anterior offset if you're far, far posteriorly. That way you can help protect yourself. So wherever your aiming beam is, your laser will fire anterior to that aiming beam. So, or opposite, if you're right behind the lens and you're worried about hitting the lens, you can do a 200, 100, 300 micron offset, let's say, and that will fire the laser behind where your aiming beam is, just to prevent you from, let's say, hitting a lens. So if the shock wave is 300 microns and you do a 300 micron offset, that means wherever you're firing, you should not hit anything right beyond where your aiming beam is theoretically as well, or very close to that. So that's what the offset does. It helps too when you're going posteriorly because of parallax. So that's how I use it. Majority of the time though, I keep it as 0 offset and I just move anteriorly posteriorly with my laser because you can see where the plasma is firing. So I use it 0 offset for most of my cases, only those extreme cases where I'll anterior or posteriorly. How about you guys?
Yes,
Ahmed?
Yes, exactly as you said. But I don't exceed the 100 micron offset, whether the anterior or posterior. I'm a little bit worth of 200 microns, so I prefer all of the time to make it just 100 micron offset, whether if it is near the lens to make it posterior, if it is near the retina to make it anterior offset, most of the time.
So for me, it's exactly the same. So in majority of cases, I'm using 0 offset. However, if you remember my case with sub-IOM hemorrhage, that's the case where you need to be extremely precise. And for me, offset there works like a very precise knife. And I'm starting with high offset in such case. If I'm slightly over retinal surface, it's very unusual normally, but I'm starting with largest possible anterior offset and then decreasing it a little bit just to see what happens. And then it's like something what makes me very confident in terms of the distance. And the same if I'm getting very close to the lens for some reason, and I'm not willing to hit the capsule, even in pseudophakic patients, then I'm using higher posterior offset, and then I'm decreasing it. So very different applications, and it's good to have continuous offset.
So Paul, you mentioned your power settings sort of heading around 4 or 5 millijoules, and then the total energy that's put into a particular session. Is there a threshold for a single session where you said, okay, that's enough energy for today, anything more, I could be running up into trouble with pressure, etc.?
So, great question. I don't have an upper limit 100%. I've done 2,000 shots at 6 millijoules and had no problems. But I've learned over time that the more anterior the floater is, so closer to the lens, especially in a YAG, capsule, post-YAG patient, there is a little bit higher risk in our hands if you do too many shots at one time for the pressure to go up. So if it's more of an anterior floater, I will limit to about 400 or 500 shots. Not that you have to, but I just want to be safe. And since I've done that, I haven't seen pressure spikes. When I went to 1,000 shots, let's say it was more anteriorly, I did have a few patients with pressure 50. I've had a 60 or, so it can get high enough. So that's kind of why I limit it. And also it's also number two, rather patients get, if it's been like 10, 20 minutes, you're firing, they get tired, gas bubbles float around, and so you get your visualization goes down, then I'll stop. But we've done ERG testing, dark adaptation testing, which is something called the maculogics, and we haven't seen any decrease in retina functionality, even doing 3 sessions over time. So I'm not sure if there's an upper limit, but I think it's more or less more practical upper limits.
Do you give routinely post-op anti-glaucoma treatment?
I don't use any, good question. I don't use any drops at all, whether it's NSAIDs, steroids, or anti-pressure drops. But I will say if I do have a glaucoma patient, I will follow them more closely just to make sure they don't have a pressure spike. And if it does happen, we have a pressure spike, Diamox works beautifully for some reason, more than anything else. Just with one pill, you're done. But more importantly, SLT, if it doesn't come down, SLT has worked really well for these patients, which is why I think there's some type of a physical blockage of material, like a pseudoexfoliation kind of patient. That's kind of my experience. I'm not sure if anyone else has that experience.
Even lubricants, you don't give lubricants for post-LASIK procedures, pseudophakics. You don't.
I don't give any lubricants. I mean, if they have dry eye, I'll make sure they continue their ocular surface treatments. But I usually use like a cysteine gel or like a viscoelastic as a coupling agent, and it usually doesn't cause significant surface issues. But again, whatever is best for a patient, absolutely.
Maria, Andre, any pearls about procedure, like limit power yet?
Yeah, we had so many discussions with Paul when we were running courses together regarding like what's the maximum number of shots, what's the total energy you wouldn't exceed, and there's not like one solution for everyone. Every one of us is different, has different patients, has different practice, and even if you perform a couple of thousands of vitreolysis procedures, still our patterns can be very different. And for me, it's still like usually during courses, I'm telling people, look, try not to exceed like 500 to 600. But there are patients where I do like 700 to 800. Still, my maximal energy would be like 6 millijoules, 7 millijoules in many cases. But that just depends on your practice, on specific patient. If you did 2 or 3 sessions and it worked well with higher settings, and there's no IOP spike, and you're not doing something within the anterior part of vitreous, then you can easily go on, right?
Yeah, to your point, we did a study where we found that really there was no significant benefit in terms of efficacy of going above 7 millijoules. So I agree with you, Andy, but 5 or 6 after that, I don't really go higher and higher energies just because it hasn't seen a significant benefit.
And so can you comment about benefit? Benefit meaning like benefit how?
Well, I didn't see it was any more efficient. So let's say there was I went to 8 millijoules, 9 millijoules, 10 millijoules, then to see was it better in terms of breaking up the floater or causing vaporization. We didn't see a significant increase in efficiency or outcomes, so to speak, like at a higher level. So pretty much at 5 or 6, I kind of stop. I don't really go any higher from that perspective.
But I think it's more important to remember about using double or triple burst instead of using very high energy, because it would give you definitely more space in terms of how you work. Sometimes it's much better to have triple burst with 5 or 6 rather than have one shot of 7, and it's definitely more effective then.
That's a really good point. If you have like a large amorphous cloud, going to double or triple burst, it means every time you fire, there's 3 bursts of laser energy going there, which can help efficiency. Absolutely. That's a great point, Andy.
Good.
Nathan,
Marie, any final thoughts on this? Yeah, I think so.
All right, man. I don't know. That was good. Good discussion, guys. Thank you for that.
All right. So I guess we're coming into the last 15, 20 minutes. I'm going to just jump in and give my session, and then we can obviously continue with our discussion. Okay. I think you can all see my screen.
Yes.
So hopefully this this aspect of the final source is a lot of what we've learned, as well as our experiences, and you know, I'll share my sort of experience as well as best practices as a vitreoretinal surgeon that deals with vitreous opacities, both clinically with YAG as well as with pars plana vitrectomy. This image in the back actually is one of our staff members who reported floaters, and you can see on the depth resolution of the OCT, you can actually see this sort of bird shape or M-shaped floater hovering over their macula. These are measures. I'll be showing images from a variety of devices. I think at this point, all of us know sort of the basic anatomy of the vitreous, primarily water and collagen bound together. Over time, you know, this is something that I do explain to my patients in a lay way, just making sure they understand why this is happening. They're aging, the collagen and hyaluronic acid, as well as the water, decouple from one another, causing aggregation of collagen fibrils, which we call as liquefaction or vitreous degeneration. And so, you know, it was touched upon earlier about in terms of the impact on visual function. I think, you know, we've seen study over study talking about impaired reading vision, microperimetric function, reading speed, contrast sensitivity, and of course, quality of life, as we saw with the AJ Oda article that Dr. Ahmed presented upon. But when I'm speaking to my patients, as I mentioned earlier, really trying to tease out what is the impact to their life. You know, is it are they unable to work anymore, draw, paint, fly a plane, play golf? You know, I've had patients come to my office and say, you know, I can't see the ball when I'm putting. So these are ways to be much more concrete about the impact on how it's affecting the patient versus, well, your acuity is 20/20, which is often the case. And so, you know, a number of years ago, a classification was approached in terms of how to classify these vitreous floaters. And I know this morning we've been talking about the various types of floaters, whether they're Weiss rings or amorphous clouds. And I don't know that we have a great way of classifying an entity that presents so differently. The literature continues to grow. Paul and others have been instrumental in expanding that literature and understanding this is a science. Shaw and Heyer presented in 2017 a randomized controlled trial on treating vitreolysis ring ag laser versus sham. And again, that was the central article that sort of set off some of the discussions we're having today. Assessing the opacities, you know, Andre presented a variety of different options: clinical examination, OCT, ultrasound. In the old days, the optometric community had developed something called a vitreoscope, which also was used initially to look at floaters. CBAG shown some nice example and some nice work of ultrasound in this approach. But you know, in my experience, you know, when I'm looking at these patients, ultrasound is a little bit more limited in resolution. It's nice to see the study that we saw earlier with Paul and Andre looking at the motion of the vitreous, which isn't very significant, which probably gives us our answer as to why we don't get many tears or detachments with this technology. When I'm evaluating patients for vitreous opacities, I definitely focus on symptomatology. You know, is it a constant visual disturbance? Again, is it impairing their activities of daily living? Long-standing, it's got to be at least 6 months. Why? Because again, every PVD under the sun will show up in your office complaining of floaters within the first period of time that they've experienced the detachment of the floater of their vitreous. So giving them some time to neuroadapt and making sure that you're not taking everybody to, you know, a procedure that they could otherwise avoid. And then examination, obviously, from my perspective, it does need to be visible on clinical examination. If I can't see it, I can't treat it. I do like to use imaging, and we'll talk about what that looks like for us. So confirmed on imaging, it should be located in the central visual axis, at least make its way to the central visual axis. I do use Paul's Volk lens for examining the vitreous and treating patients, which is excellent. I encourage you to explore it and try it if you haven't already. But if you can't see it at the slit lamp, you're going to have a hard time treating it at the laser. And then absence of any concomitant peripheral pathology. So if they have active you know, flashing lights or floaters from lattice or holes that are open with fluid, you know, I'll make sure that those are dealt with before we engage on this journey to deal with their opacity. So how about imaging these? I mean, you know, I've spent the better part of my career now looking at retinal imaging and imaging vitreous opacities in this case. That's probably one of the nicer ways to do this that's readily available in our office. Here are 4 different cases of 4 different eyes with floaters that presented. They all look somewhat different. And this can be actually quite helpful in the clinical setting in at least corroborating that you're seeing what the patient is complaining about. And again, as Ahmed mentioned earlier, having the patient draw out their floaters is something that I also do as much as possible to see if we can co-localize what I'm seeing at the microscope imaging and what the patient's seeing. The worst thing would be to treat something that you thought was bothering the patient, but it's not bothering the patient. And as mentioned earlier, they call you the next day or call you the next week saying, look, I'm still the same. So we developed a few techniques in the office to help with this process. Here's a figure up above. The above scan shows an unaltered swept source OCT. And then you can see when we increase the gain, you can actually see greater vitreous detail, about 75% increase. And so here's another example of using this SLO and dynamic OCT evaluation to assess a patient's floater. You can see on the left, they have a focal opacity, which moves across their view. And as Ahmed mentioned also, and Marie mentioned, you know, the shadow that's cast over the macula or over the retina can be seen here, the umbral cone. So you can actually appreciate the extent to which this opacity is casting the shadow. And there's our opacity. So what does this look like when it's an amorphous cloud? Here's our patient, and we're having them alter their gaze in different directions. And you'll see on the OCT, in the area where the vitreous is located, you'll see a cloud of hyperreflective floaters just slowly migrating over their vision, casting very tiny shadows. And so in this particular disease state, patients present differently. Some will have focal opacities, some will have diffuse opacities, and their complaints may vary. But being able to corroborate them has been one of the challenges in our field in confirming that what the patient's reporting is in fact happening. And I think some of these modalities, as you can see here, do a much better job of that than just looking at them at the clinical examination stage. What about looking at the vitreous en face? As a retina surgeon, obviously, and as a retina specialist, we look at the retina en face, and we developed a technique here with one of our devices where we can actually look at the vitreous en face. So you can see here the optic nerve is visible, right? And then the premacular bursa. And when you actually get a high mag view, you can actually see individual vitreous fibrils. And so while an individual fibril may not be the source of a patient's problem, improving our techniques to image this area of the eye is an issue and something that we're working on actively to improve. So here's an example of a patient with the SLO image on the left and their en face vitreous on the right. And you can actually see that opacity in both views. Much more larger, obviously, with the SLO image because of the magnification, but you can definitely appreciate the fact that this is located in the vitreous. Now, down below in the transverse section of the OCT, you don't see anything, and that has to do with the resolution of those types of scans. So, you know, taking a multimodality approach to this, whether it's your clinical exam, ultrasound, OCT, SLO, what you feel works best in your hands, I would explore different options so you can correlate and corroborate what the patient's seeing and what you should be seeing. Here's another example of the actual opacity moving as the patient moves their eye. And this is a vitreous OCT, and you can see the opacity that the patient was experiencing. And they drew this exact sort of amorphous little focal area out to me and was able to correlate it with the vitreous OCT. So what are these ideal YAG candidates? You know, and this is my perspective. Of course, our group has their own experience, and I think a lot of this does converge to some extent. I think especially when you're starting out, you know, small opacities, they should be focal, singular in the central visual axis. They should be visible on your contact lens exam, because if you're doing a YAG vitreolysis, often you'll use some sort of contact lens exam, as I do with Paul's lens. And obviously identifying whether they're in the anterior or mid-vitreous. And then in an ideal scenario, they're a pseudophakic patient, because that gives you some confidence going in early on that you can expect a good outcome. We can see here the Optos image above for this patient pre-YAG vit. They have a Weiss ring, which you can see on the SLO image, and then post-YAG, the Optos image and the SLO image also show the absence of that opacity. So, you know, using some of these benchmarks to also show to patients, hey, you know, you complained of this, I went after this, this is the images now. I think some of this pre and post education is also helpful for patients so that they see that something was actually done. And most of the time they appreciate it because they themselves are relieved of their symptoms. But in some instances, as Ahmed pointed out, there are residual fragments that the patient's bothered by, which may not be picked up on examination or imaging. And so it is useful to have these benchmark pre and post images to help counsel and educate the patient. And you can see here on the bottom right, this is the SLO video now. There's no real white ring. There's some other fragments within the vitreous that were previously present, the posterior face of the vitreous, but not so much this white ring. So who are the ideal vitrectomy candidates? I think, it's kind of incumbent upon us as retina surgeons to also comment about this. And as Paul said, yes, it's not a competition. We're not competing vitrectomy with YAG vitreolysis. It's always ideal to the less invasive procedure on the patient when it's appropriate. So in my experience, having these diffuse amorphous opacities that are non-centric, or they're incompletely visible on examination, they're difficult to access with the laser. If they're located in the posterior 1/3 of the vitreous, that can be quite challenging to laser, and or if they have a pre-existing cataract. As a cataract and retina specialist in Canada, we have the luxury of being able to do combined cases. So in situations where a patient has a cataract and floaters that don't meet YAG vitreolysis criteria, I don't hesitate to do combined surgery to get them where they need to go. And so here's another SLO example of the video of this diffuse opacities as the patient moves their eye. In my experience, very challenging to deal with laser alone. What are the complications or side effects? Cataract, as Paul pointed out, is possible, if you really don't judge the distance properly between the posterior capsule and the opacity. It has happened to me where the lens capsule has been touched. Retinal tear and detachment is a theoretical risk. I haven't yet to see it. And the same was true in the Shah-Hire paper where they did a randomized controlled trial. In fact, the one patient that developed a tear in that study had pre-existing lattice and was in the sham arm. So again, as we saw with the ultrasound and the vitreous dynamics, the vitreous moves very little with this technology. And as such, we don't likely see many tears and detachments. Endophthalmitis with vitrectomy is much more likely, but not so much with YAG vitreolysis, of course. And vitreous hemorrhage, of course, is something that we can see more with surgery, less so in the case of YAG vitreolysis. So, one of the complications that is worth talking about is a retinal strike. Here's an image of that on the far right, and I'll image that out there for you. You can see it. The laser power generally used for treating vitreous opacities is quite mild. I know our audience mentioned, our panel mentioned somewhere between 4 and 5 millijoules. I've gone higher than this, and I find that it does limit the number of sessions that are required for patients. So there can be some benefit from that perspective, but there is an energy threshold where you can experience elevated intraocular pressure. In the case of this one patient that had a retinal strike, the anatomy as well as the scotoma improved over time. There wasn't a true scotoma because the power that's being used is so slight, but it's still an undesirable event. Fortunately, outside the macula, that opacities that are too close to the retina probably should be avoided regardless of what the offset is on your machine. So really, in conclusion, I think, in my experience in doing now several hundred cases, probably bordering on 1,000 cases, and we published a paper recently that's being accepted for imaging and sort of identifying these opacities in a more concrete manner. It's a less invasive, relatively safe option for patients with the right type of opacities. OCT offers a nice approach to being able to identify these opacities, and using an on-FOS approach actually is quite a bit more meaningful. And the ideal candidates, especially when you're starting out, should be single focal visible opacities residing in the central field of view. And obviously having a long discussion with the patients about the risks and benefits. And, just getting back to some of the questions that I asked the audience, my conversation with these patients is often quite deep. And it does center on the fact that if there are residual opacities that are unable to be lasered after the fact that the patient is bothered by, vitrectomy is always an option. So the goal is always do no harm, of course, but try to, in every circumstance, to satisfy the patient's issue. And as we've seen, those issues can be quite significant and can be significantly debilitating to their life. Thank you.
That was great, man. Fantastic stuff. I love those images. It's beautiful. Let me ask you. Oops. Oh, sorry. There we go. Let me go back to, there we go. My computer's messed up here. You can see half my face. I have to ask you a question real quick. So with the on-FOS, I may have missed it, but with the on-FOS OCT, are you offsetting your OCT to get that image?
So the OCT actually has a 6mm depth resolution. So a traditional OCT is about 3mm. This is 6mm. So you're actually able to look at the vitreous in that en face way.
Yeah. I think it is really marvelous, those images, and it's so important to see that the patients who have opacity so close to the retina, those are most of the time very young people. They don't have a PVD yet. And then you could eventually say, yeah, let us wait a little bit until you have a PVD if they are close to the 40s, but you can then also wait a little bit, quite long time. So that's a little bit, the problem. But I think that I do not know the floaters. The closer they are to the macula, the more pronounced they will be. The more the patient will complain about them because they will be considered as quite dark. On the other hand, we don't see them so well. You see them on the en face, and we sometimes do see it also on the regular OCT, but you cannot reach them with laser. That's for sure. And that's the reason why we most probably will have to discuss in the research webinar, most probably, what are the indications for vitrectomy, which kind of vitrectomy, etc., etc. Because I think that there we cannot help the patient. As the closer it is to the retina, and certainly if the posterior hyaloid is not detached yet, I think that there we have no other option than propose eventually a core vitrectomy. I think so. Well, okay, that's a matter of discussion.
So I agree with you there. I think with the opacities that are closer to the retina are more challenging. Just in the interest of time, when we're talking about vitrectomies, I generally do a relatively complete vitrectomy on patients, not just the core. I elevate the hyaloid and trim it out. One of the rationales for that is that, you know, if you're already there doing the vitrectomy and you don't lift the hyaloid, a few years from now, or even in months from now, the hyaloid will separate, and now they have a new floater in their vision. They'll say, "What did you do?"
Yeah.
So, you know, there's obviously risk to this. Have I done vitrectomies and a patient had a tear or a detachment? Of course, following within the general statistics. But these are patients that are motivated to the point where, and you know, this is how you know you picked the right patient. When a patient has a tear or detachment after a vitrectomy and they say, "It was worth it because I was going crazy," then you know you got the right patient. And so invariably the statistical events of these are quite small. It doesn't mean that we're cavalier or treat them lightly. But again, back to candidate selection and trying to solve the problem, being definitive is key.
Okay, but so you lift the posterior hyaloid and you do a total vitrectomy, because then you don't protect your posterior capsule anymore with the anterior hyaloid and with the anterior vitreous. And of course, then the patient will develop cataract quite quick or quite soon. So what do you do then? You lift the vitreous and you do then half of the vitrectomy, or you do a total vitrectomy with laser over the 360 degrees?
So there's no laser involved, but you know, again, the patients that are getting vitrectomy may be pseudo fakes themselves because they've had cataract surgery, they've had a YAG, there's a bunch of stuff floating around.
Yeah.
There's that category. There is the phakic crowd that's 50 and over that would otherwise elect to have their cataract taken out. No, and then there's obviously the under 50 crowd where they have a, you know, clear lens, and for them, the floater is imperative. They know they may get a cataract down the road. So doing the core, lifting in the hyaloid, trimming out to the periphery, you know, not shaving and doing a detachment style vitrectomy, but doing a thorough job so you're not back in there later explaining to the patient why there's something still flopping into their vision.
Yeah, okay, that was also my approach, I must say, because I'm quite interested in the anterior interface, which is as important than the posterior interface, I think, certainly regarding the preservation of the integrity of the lens. Thank you very much for those beautiful images. Very nice.
Nathan, just a quick question, because I was really astonished by your pictures. So thank you for showing them. Just one question. There are lots of vitrectomists claiming that they're performing floater-only vitrectomy without inducing full PVD. What do you think about it? Does it make any sense to perform floater-only vitrectomy in a young patient without inducing PVD?
So I think, you know, it's a temporary fix, but you end up creating, you know, you're jarring up the vitreous, you're still creating traction in areas you don't know, and the hyaloid may separate later, which it obviously will, and then they'll have a new floater. I think if you're in there to be definitive is a good idea. ultimately, what are we protecting? We're protecting the crystalline lens. And, you know, again, that's a conversation with the patient to explain, like, you know, if you're 20 years old, I don't necessarily take people to vitrectomy for the most part. That would be a little bit much. But, you know, having this discussion with patients is critical. I don't see in my hands doing a floater only vitrectomy as being meaningful to the patient, because they'll develop something else as their vitreous continues to age.
Thanks.
That was a great discussion. Wow. Well, I wanted to, first of all, I know we're at time now. And, I want to thank all the speakers, you know, Ahmed, Andy, Nathan, and of course Marie for joining us for the panel. You have always fantastic pearls to teach us. But I want to thank you all out there in the world for joining us. Please spread the word on the International Ophthalmic Floater Society. It's a society that's open to new members, so please feel free to log on to our website and also, you know, become a member. We want to work on more education. This is not just about YAG laser. It's about really understanding floaters, the diagnostics, the treatment, multiple new treatments that hopefully will be coming out, research, combining our data. So we need you all out there in the world to help promote the importance of not ignoring floaters. That's the bottom line. With that said, Andy, do you want to just promote the next session, give it the dates and times for the next October session again?
Thank you, Paul, because we're going to co-moderate the next webinar, which is going to be on 15th of October. So you are more warmly welcome to join us then. And so you're going to see new images, new people coming. So I guess it's a lot of things to see there.
And also, I would like to say that there is a last webinar on the 2nd of December, and that will be more on the research. And we will also speak about the visual snow syndrome, because that's also a confusing entity. And I think that this is also something that we have to understand about what it is really. So I would like to thank you all, guys, the people here organizing this first webinar. The fact that it was really interesting is that all those who connected, they stayed up till the end very much. So means that it was really interesting. Thank you very much, and see you soon, and enjoy your weekends.
Thank you.
Bye, everybody. Thank you. Well done, everyone. Bye-bye.
Thanks, everybody.
Bye.